Recording.
Go for it.
There you go.
All right.
All right.
So go for
Go
it.
ahead.
Do I just introduce myself?
Yeah, we're just gonna get into it. It's fine.
Okay. Sweet. I'm Dr. Raymond San Agustin in Calgary, Alberta, with Dynamic YYC Movement Lab. I graduated, I think, like 3 years ago now. Just a little over 3 years ago. I was an MPI rep throughout Palmer, and R2P was just starting, so I wasn't like huge into it. It was just like, again, it was like just starting out. No one really knew what to do with the clubs back then. So, but I'll talk about a couple of cases. I'll talk about a zebra case first, just because it's cool to hear that your job isn't just about poking butt cheeks and armpits all the time. So you get to actually be a doctor every once in a while. So let me just pull up the patient file. I have to like look for it. It was pretty interesting. So he was an avid, I'll get the ages and everything afterwards, but he was an avid motorcycler. And here in Calgary, you have about 2 to 3 months of the year to actually motorcycle, because the rest of the time it's either covered in gravel or ice. And with COVID, more people were actually just going out. And that being said, I just gotta figure out when that was. We have satellite locations and we have a main flagship location. These were out of my satellite location, which operates out of a CrossFit gym. So it's pretty cool. You get a little bit of a mix of like your everyday folk and your weekend warriors. And from this, I saw this patient. He presented with neck tightness, and let me just double check. I want to make sure I have it perfectly, because there we go. Sorry. So he presented with neck pain and I think like gradual arm pain. So we see this super often. This is just like, I'm not a huge believer of trigger points in the sense that they think it's a magical point. However, the literature all seems to agree that there's a tonicity in the muscle. When it is stimulated, it creates a referral pattern. It could be different from person to person. Janet Travell's book is a good bell curve of representation. It's pretty cool when you see like an exact representation of what happens, and it happens far more often than you think. And we see it a lot. Like lat will present down the arm like this. It's just like kind of one of those clinical expertise things that you kind of develop, and you're like, oh, I've seen this before, it's fine. But if you think about a motorcyclist, especially someone who rides for many, many hours, there's a couple of things that are going on. They're stuck. And depending on the motorcyclist, you have to ask them what kind of motorcycle they're riding or things like that. He's on a crotch rocket, so you can imagine they're in this position for a long period of time. So the neck pain, under my assumption, just based off of history and a long period of riding, you would just think being stuck in like a little bit of flexion plus extension of the cervical spine. I automatically thought it was going to be purely mechanical, just simply off of that. Long positions held for a long period of time that you're just not really used to, not to mention the amount of vibration that happens with motorcycling and the tonicity and the tension that a lot of people do or hold while they're riding for long periods of time. We have like an area that's called Kananaskis or Bright Creek, just outside of the city, where there's like a lot of curves, so people go out riding because there's less cops there, and that way they can kind of like, it's like a sport for them, for example. And I was just like, oh cool, this is pure biomechanical for sure. Like it just sounds like they've been cranking on their neck for a long period of time. The tension in their lats are just like never training overhead. This guy's was not a gym person, so for sure just not a position that he would normally be in, and then all of a sudden ramping up his volume for it. And so I treat him as if it was biomechanical, like pure and simple biomechanical. And this is where getting histories are very, very important, is because it was like a low grade pain down the arm. Like, again, we see it so often. I was like, for sure, it's just biomechanical. So I treated him as if I'll talk about some of the orthopedics. Let me just double check, make sure. Cervical Kemp's, there was pain with left lateral flexion and rotation, nothing on the other side, and it reproduced pain. So even if you look at some of the sclerotogenous referrals, like it goes into the scapular region. And this is kind of where he was just presenting with pain. I was like, okay, cool, levator scapula for sure, just getting overloaded. And then cervical compression would create joint line pain along the base of the neck, so at the cervicothoracic region. And then he had decreased active range of motion, but for the most part, all of it was within normal limits. His left rotation was decreased and his left lateral flexion was decreased. So again, sounds very, very, very biomechanical. And lift, I always check with neck pain, I always check lift off. I think it's a very good test to check. Because it's a subscap test, you could kind of see if they're lacking range of motion and internal rotation, the next best option is almost always like dumping into the scapula. But there's a caveat to that, because most people, and this is like a clinical thing that we just see, their dominant hand will always have a shittier lift off. Like it just, you can almost guarantee you just, if you ever want to like get buy-in from a patient, it would be like, you'll do the test and then you'll see which one has less. And you'll be like, oh, you're left-handed or you're right-handed. And like, oh, how do you know that? And it's also because it's like counterintuitive. Like you just would never think those things. And then, so I just treated him. And this guy, like our treatments are different. We have 25 minutes as our typical chiropractic treatment, and then we have a lengthier one, which is 45 minutes, which is unusual in Calgary. Like no one really does that, and we're only a little bit more expensive than the regular, like the other chiros in Calgary. We do that, and like I've had chiros tell me they're like, you're undercharging too much in terms of time, and we're like, no, we want to change the industry. We don't care. Like we want you guys to catch up to us, not the other way around. Like, I don't want to have to charge more, because like, it's obviously going to bite into your salary, but like, I want to know that I'm doing honest work and I'm getting people better. But anyways, I digress. I could talk about that enough. And so this case, I treated his, like, we do a lot of muscle energy. We do a lot of like, it's similar to FR, like a lot of like compression of the taut tissues, and then you load it into where you palpate. And I just treated his shoulder, his neck, adjusted let me double check what I adjusted, his thoracic spine and his cervical spine, and I sent him on his way. He loved it. And we are very heavy-handed. People either love it or hate it, and we just kind of lean into patient preference. This guy loves getting his ass kicked. So he just like wants like a lot of pressure. He wants to feel like he got a treatment. So you just lean in, and he was like, oh, I feel awesome. I booked him in for the next week. I almost always do a week after. Even if they feel good, like even if it's a maintenance thing, I just want to see what worked for them, because sometimes with our joint loading stuff, it's just like if they're undertrained, we just light them up too much. They're like, I was sore for 3 days, and it's like, okay, well now I need to know I have to back off. So it's also creating that rapport. So we always do a follow-up the week after an initial, and it was way worse, like way worse. Neck pain was worse, arm pain was worse. He had weakness in flexion of his hand. He can no longer do it. He would have to, and I'll show you, he had to do this to spread out his fingers. And the crazy thing is, he goes, I'm like, when did that start? He's like, it felt good for about a day, and then it started getting worse. And I was just like, why didn't you book in earlier? It's like, I figured that I'm going to see you next week anyways. I could wait till then. And this is where patient education can sometimes, like, you just forget to tell people they can book in. They don't have to follow your treatment schedule just simply off of that. Because like people just don't know. Like, so sometimes you forget that people don't have the exact same knowledge that you have, or that it's like you'll get two ways, like people who just don't want to go anywhere else, so they'll just wait, or people are like freak out and they'll just go to the emergency, which I wish he did. So I get him in, and I test muscle strength. It's like absent in flexion. In extension, it recreates pain. His neck there's like a muscular torticollis, and I was just like, what the hell is going on here? Like, this is super strange. He's like, I just thought it was normal. Like, I just thought sometimes you have to get worse before you get better. And I was like, I'm not under that school of thought. I think generally if you get worse, it's either we did something that was too much, or we just need to pivot and completely try something different. But I was like, you need to go to emergency. Like, this is not, he's like, I thought this is normal. I thought it was just like muscles pinching down. I was like, no, muscle weakness is not normal at all, like by any means. And I sent him to the emergency room. I wrote a referral letter. I didn't even charge him for that appointment. And he went straight in. I called him later on that evening, and I wrote a full referral, like his history, things like that. He got admitted right away into Emerge. And then he got admitted into a neuro unit while they did CT, MRI, and all of like a bunch of imaging, the benefits of being in Canada. And they did like a vascular CT to make sure it wasn't a stroke, like a CBA. And I called him, and he was still in the hospital a week after. Like, I kept calling him like every couple of days to see what was going on. And he got diagnosed with Parsonage-Turner syndrome. Let me double check the name of it. PTS, Parsonage-Turner syndrome. Have you guys learned that? Yeah, me neither. Like, what the hell? So I look it up, and I was like, oh, wow, man. Like, on the phone, do not show them. Like, don't give any inkling if you have no idea. It's just like it's a idiopathic neurological disorder, like, and sometimes it happens after surgery, sometimes it just happens, but it's like a progressive weakness and pain in the neck and the arm. So it's like a neuritis or whatever, and that's what he got diagnosed with. So they just treated him with corticosteroids, and he was good. Like, he got discharged. I haven't seen him since. I called him after. He's like, I'm fine, man. So it's pretty interesting because I probably saw it on the onset, completely thought it was biomechanical, and things can change quickly. It was a very, very huge awakening on patient teaching. And also like he at the end, when I sent him to emergency with a referral, he's like, you're not going to treat me? I was like, hell no way. Like, I don't even want to, like, get out of here. I do not want to see you. I want you to go to emergency, and I want to talk to you after. And that like 3-tiered chair of like patient preference to like clinical expertise and best evidence available. Sometimes what a patient wants is not what you should be doing, and but sometimes it is, and that's like a perfect example, because I leaned into what he wanted the first time, and then I did not lean in the second time. Like, I sent his ass out. So yeah, it was crazy, because I just never would have expected it to escalate that quickly.
Yeah, Doc. So so it sounds like instead of, it's not necessarily, I guess my first question would be, if you could go back to that first treatment, like, would you have changed anything?
No, for sure. It's just because the presentations, like, it didn't warrant anything. Like, there was nothing that would have even led for me to think that at all. Like, I remember seeing him the second time and being like completely floored with this progression of symptoms that were like, it just never would have presented with any, like, yeah, And with orthopedics, you're pretty much doing nerve tension tests anyways, and none of that came out. Like there was nothing there that would have pointed me in one direction or the other. So like I think being prepared for changes is also important, because patients want to know that you're trying to figure things out, but it's not always clear cut.
Yeah. So instead, just like the idea that, you know, when the patient does leave and saying, like, letting them know, like, hey, if this does get worse, you know, like, let me know, like, contact me, and so that we can
Yeah.
figure this out. Yeah.
Well, and honestly, like I never would have thought I would have had to say that explicitly, because it seems logical. Like it just seems like something someone would do. You're like,
Mhm.
hey, I felt great, and then it got worse. Like, just call me. Like, do something. We have a phone number. Because I would have told him to go to emergency like 2 days after instead of him waiting a week.
Right.
So, yeah,
No, that's not a, like, not cool, but that's a cool case. I think
yeah,
just
yeah.
because,
It
like, if
was,
you think about it, you know, no matter what we would have done, I think, you know, no matter what our biases are in terms of how we treat, um, you know, especially like giving the patient what they want, you know, if it's a mechanical thing, like, um, you know, I think a lot of things could work, and you kind of went with what you're good at and what you like to use and what the patient wanted. And um, I don't know, just,
we don't do much. Like our practice is just hands on.
yeah.
Um, it's like disguised exercise essentially. If you guys have taken FRC or FR, it's like that's essentially what we do. It's a little more. I think it's a little more just because we're a bunch of meatheads that work here. Um, but um, yeah, that's it. And like exercise, like we're in gyms and we have all this stuff, and we adjust just because not everyone, but yeah.
Right.
Any questions on that one? That one was like a super cool case. And the fact that like I was okay with knowing that I wasn't gonna be the one that was gonna heal him or whatever, get him better. I think that's hard for people to come to terms with. Like you're not gonna be a part of the care all the time. You're not gonna be the one for the care. We get into it wanting it to be, but
Mhm.
a lot of times it's just not the case.
Yeah. Well, I know, like, at UWS, we have a soft tissue club, we have MPI, we have R2P. So, like, there's a lot of information, and, you know, we try to, like, you know, give a lot of tools and everything to treat. And I think, you know, when you take all those into consideration, it's easy to come out of school and think that you can save everybody, you know? You're like, oh, well, I know a little bit about everything. Like I got enough tools in this box, like I can figure something out. But to be able
Yeah,
to, like, step back and be like, no, this is not me.
it's hard, and like I think it takes practice to learn that too. I actually don't think you'll come out knowing that all the time.
Mm,
Um, and I mean, also it's different here in Canada. Like we have a lot more available to us in terms of like without a barrier. Because like I could send a patient to a specialist pretty easily, and there won't be resistance there because they don't have to pay out of pocket for it. Like they'll just be like, okay, cool, and then just go there. Um, which is actually really interesting for my next case. Like I'll talk about this one. This one's actually a really cool one because it's almost the exact opposite. I wanted it to be something else, and I didn't want it to be something else for the sake of me. I wanted it to be something else for the sake of the patient. So this is actually like a
Hey, Doc, real quick,
yeah.